Good afternoon and welcome to today's webinar, Telehealth Evolution in California. Where are we and where do we go from here? Today's webinar is presented to you by the California Healthcare Foundation, the California Telehealth Policy Coalition, and the California Telehealth Resource Center. With that, I'll shift us to our presentation. I'm Diane Camacho. I'm a Senior Program Officer at the California Healthcare Foundation. I will be presenting the findings of CHCF's recent report on telehealth with my colleague, Natasha Aurora, with the Center for Community Health and Evaluation, who I will welcome onto the screen shortly. Next slide, please. Our presentation of report findings will be followed by a dynamic panel of telehealth leaders moderated by the nation's telehealth policy guru, Mei Kwong, with the Center for Connected Health Policy. Next slide, please. Natasha will be providing an overview of CHCF's recent report, Telehealth Evolution in California, Progress, Challenges, and Opportunities. CHCF has long invested in telehealth as a way to increase access to care for Californians that experience barriers. CHCF commissioned this report to reflect back on decades of learnings in telehealth. This report celebrates its progress, extracts valuable lessons, and identifies opportunities going forward to ensure that telehealth continues to enhance, not hinder, equitable access to care. I want to thank the people that made this report possible, the Center for Community Health and Evaluation, our advisors to the project, all those interviews, many of whom I'm sure are on this webinar, and our sponsors for today's event, the California Telehealth Policy Coalition and the California Telehealth Resource Center. Next slide, please. You can access the report and recommendations by stakeholder type using the QR code that will drop in the link. Next slide, please. Before I hand it over to Natasha, I want to center the conversation on the voices of people that benefit from telehealth. Next slide, please. You'll see here some quotes from interviews CHCF conducted with Californians on the benefits of telehealth that illuminate how transformative telehealth is in increasing access to care. Next slide, please. With that, we'd like to share a video of those voices of the people that we spoke to as part of our report.
Hello.
Hi team, this is Dr. Chung. How are you doing?
I lived at a time when the doctor did house visits, house calls, and actually I compare this to that. I feel like I'm having house calls again.
I think having telehealth is awesome. It gives you an option, especially for people like me who suffer from anxiety. One minute you be okay, and the next minute you be panicking. You be like, oh my God, I gotta go to the doctor. Oh my God, I gotta go outside and let out, And then you could just make that call and say, can we switch it to, a telehealth, because right now I can't. I just can't go outside. So it works. It works.
I'm a student at Cal Poly Humboldt. Telehealth has really addressed a lot of my needs. Living up here in a rural area, getting labs, seeing a specialist, it can be a very long wait. When students aren't able to access healthcare, I've usually seen them turn to substances here. Telehealth really helped me access safe healthcare a lot easier.
For people like me who have so many things wrong, and if I walk 10 steps I can hardly breathe, telehealth has really helped me in that way.
Your breathing is okay, right? You're
My
not short of
breathing,
breath
my
or-
breathing is good. My breathing is fine. And I have this doctor, his name is Dr. Chung. I trust Dr. Chung 100%. I truly believe that Dr. Chung doing telehealth with me has impacted the bonding in our relationship in my health care. Usually when the doctor tells me something, I come home and do what I want. But what Dr. Chung tells me, all of his suggestions, I will follow through on. I feel better than I have felt in over a year.
And how did you notice the anxiety this morning? The answer is that you also utilize some other resources. You went to the group.
I like to see your facial expression when I'm sharing my problems with you, and see if you feeling me, or you're listening. When you have somebody totally focused on you, that make you so relaxed, and it makes you feel heard.
They gave me the option of FaceTime or the iPhone. And I said I wanted the iPhone because there are times I just don't look that good. But they gave me that choice to begin with. It was very important.
So a lot of shifts in positive directions over the last couple of weeks.
The people who are typically in this area who are healthcare providers are typically white and straight. In that aspect, I feel like it could bridge that gap of healthcare access with diversity. It wouldn't just be from this area. It could be someone from San Diego or even from even lower part of SoCal. Being able to open our choices up to a much broader area.
We have seniors and we have handicapped. Some just can't get out of bed. You have to make it, where it's easy for them to be able to be seen instead of punishing them because they can't get there. I like telehealth because they're making life real easy for people who can't do.
I think so far it's been a very useful tool and very helpful. If we could find a way to get telehealth to be kind of just this broad, universal thing where no matter where you are, if you need care in this second, you can get it. That would be really nice.
I hope you enjoyed that video. With that, I'll welcome Natasha Aurora from the Center for Community Health Evaluation to share with us more about the progress, challenges, and opportunities with telehealth in California going forward. Over to you, Natasha.
Thank you, Diana. At the end of the video that we just watched, one of the patients says, if you could get telehealth to be this broad, universal thing. And we looked at California's progress in advancing access to telehealth to make it universally available and found progress in many areas, which is worth celebrating. In terms of policy and financing, evolution in the telehealth policy environment has made telehealth widely available, including to patients using Medi-Cal. In terms of consumer interest and perception of telehealth, patients are interested in using telehealth and would like it to be a regular part of their care, as we just heard. In terms of research, the body of evidence on telehealth continues to grow, particularly following the surge in telehealth's use during and after the pandemic. And with respect to implementation, telehealth is now widely available to patients, including in California's clinical safety net. We're going to talk about each of these areas some more, but first I'd like to explain how we got there. As part of this effort, we reviewed dozens of documents and literature related to telehealth and conducted interviews with 27 key informants who are working in the areas of telehealth policy, implementation, and research. And this effort really reflects the expertise of those who have been working in this space and have been advancing work around telehealth. And our role at CCHE was to listen and synthesize what we learned. So with that, let's dive further into the findings. The first is around policy change, which has been a major driver of telehealth adoption. While most of us are aware of post-pandemic changes in telehealth policy, California's coverage of telehealth by Medi-Cal actually began way back in 1996. And Medi-Cal at that time was a national leader in telehealth coverage and had more flexible coverage at the time than Medicare. For example, coverage was allowed outside of rural areas. And before 2020, most synchronous telehealth was happening from clinic to clinic. For example, for specialty care access from a primary care clinic. And e-consult programs were also robust before 2020, particularly within the county health systems. And then the policy changes after 2020 came along, which were initially part of the waivers under the public health emergency and have now been made permanent. And because of these changes, patients can now access telehealth from home or from other locations of their choice. And really key to telehealth sustainability, there is now ongoing Medi-Cal payment for telehealth, and there's payment parity, meaning the same reimbursement rate for phone visits, video visits, and in-person visits. And some other supportive policies have also helped to make telehealth more available, including policies supporting broadband access, community health workers, and school-based services. Slide, please. Consumer interest in telehealth has also played a large role in its growth. Telehealth use has grown in recent years and it remains popular. And we've seen some of the reasons for this in the first person narratives at the beginning of this presentation. In terms of the numbers, the bar chart here shows the dramatic growth in telehealth use from 2020 onward using data from DHCS. And then the data in the circle graphs show the percentage of phone and video modalities out of all visits in a cohort of FQHCs in California. And that was from 2024. And so as you can see, many visits are still being conducted by telehealth, particularly in behavioral health. Slide. And patients also report satisfaction with these experiences. The data here come from several sources, including research commissioned by CHCF and results from the California Health Interview Survey, as well as a national survey from Harvard and the Robert Wood Johnson Foundation. And across all those sources, we see that patients are satisfied with their telehealth visits and they experience rapport with their providers during telehealth visits. And about half of patients found that their telehealth experience paralleled their experience with in-person care. Slide. We've also seen progress in our understanding of telehealth, with research and evaluation efforts increasing as telehealth is used more frequently. Some of this includes research on the efficacy of different telehealth modalities. And some of the key findings coming out of that work show that synchronous telehealth has convincing evidence for its use in behavioral health and chronic condition management, and that would be with use of video. And audio-only telehealth also has convincing evidence for its use in behavioral health. E-consults also have a robust evidence base, which shows that they increase access to specialty care and reduce costs. And in our reporting on telehealth implementation, we really focused on the clinical safety net, given the importance of making telehealth available in the places where patients are already getting care. This protects against care fragmentation and it allows for continuity of care. So we hope to see continued momentum on telehealth implementation in the safety net. Currently, use of telehealth is widespread in the safety net, although some continued operational changes are needed to make video visits more widely available. And within the safety net, providers have also learned a lot and shared a lot about the changes that are needed to make telehealth more accessible to their patients. And these include screening patients for digital barriers, providing digital navigation support, and health centers have approached these in many ways, really customizing their approach based on the specific needs of their patients. So we can see that a lot has been done to make telehealth more accessible and also that there's more work to do. We know that there are still disparities in utilization of and access to telehealth, including for Medi-Cal patients compared to those with commercial plans. For adults above the age of 65, for patients with limited English proficiency, and for patients in rural areas. But we know that payer and health system characteristics influence telehealth use. So the more accessible that telehealth can be made within the systems that deliver care, the more equitably patients can access it. Slide. So with that in mind, we've created a comprehensive roadmap on where we might go from here. And the roadmap is designed for the following audiences: for policymakers, health plans, health systems and providers, and researchers. And the recommendations that we generated were based on the key informant interviews that we did and our document review. When we came up with these recommendations, we grouped them under two key overarching actions. The first is to center equity. So efforts can be focused on meeting the needs of patients who already face significant barriers to accessing healthcare. And the second is to do what works. We know a lot about what works already, and we can spread those lessons. And there's also more to learn about what works and what's worth investing in. So I'll talk first about the policy-related recommendations. In terms of policy that centers equitable access to telehealth, first of all, it's critical that Medi-Cal payment for services remains in place. And beyond that, there's an opportunity to ensure that patients that are covered by Medi-Cal have the same access to telehealth as those who are insured commercially, by addressing some of the restrictions that are currently in place with Medi-Cal related to patient consent, to providers being required to provide referrals, and to the modality for establishing care. Some other policy opportunities include expanding the pool of clinicians who are available via licensure exceptions or interstate licensure compacts, and also to continue to support access to high-speed, affordable broadband connections, which are especially important in rural areas. And then in terms of policy to support the availability of telehealth within FQHCs and other safety net settings, in the places where patients are already getting care, some of the health system leaders and providers that we spoke to talked about the barriers to creating robust telehealth offerings to their patients. While payment parity has made it possible to offer telehealth, it doesn't incentivize safety net providers to offer video visits or to build the operational changes and infrastructure that are needed for video visits. Those take more resources compared to audio-only visits. And reimbursement policy could also support wider availability of e-consult. There have been changes to provide reimbursement to the treating provider, but they're currently not applicable to FQHCs. And health system leaders and providers have also talked about how confusion related to billing and regulatory challenges can disincentivize them from building out their telehealth programs. Even if billing and regulatory rules permit the use of telehealth, they aren't always understood in safety net settings. And so we encourage policymakers to attend to these issues and also to continue to support telehealth monitoring and evaluation efforts. Slide, please. In terms of recommendations for health systems and providers, our recommendations focus on making sure that there are avenues to screen for and address digital barriers. These recommendations are about making sure that communication about telehealth occurs with patients, especially those patients who might not be familiar with technology, might not have access to technology, or might have language barriers that impact their use of technology. So that includes making sure that patients understand what telehealth options are available to them, screening them for any barriers they're experiencing to getting on that technology, and then supporting patients with the practical aspects of technology use. In addition, health systems have the opportunity to develop comprehensive digital strategies that look at telehealth as just one part of their overall strategy for addressing patient health and population health. That would be going along with things like patient portals, texting, remote patient monitoring, and data sharing. And we also encourage safety net health systems and providers to continue to work toward making telehealth available in their settings as part of a hybrid care model. So this can include supporting the availability of video visits for patients, integrating telehealth into primary care so that patients benefit from easier access to care, but also maintain the continuity of care that's offered by the medical home model. Implementing e-consult, given some of the recent policy changes that do allow for payment for the treating provider, and investing in the change management and support for staff and providers who are being asked to deliver care in a new way, including support with developing those workflows and offering training to support implementation. And we also encourage health systems and providers to continue to lean into innovation and to solicit patient input to understand what works for their patients. Our recommendations for health plans are similar to those that we shared for health systems and policymakers. So similar to health systems or providers, health plans can offer a variety of digital options to access care to their members as part of a comprehensive digital strategy, and then communicate those options clearly to their members. And similar to policymakers, health plans can find ways to incentivize promising practices like e-consults within their provider network and to make billing as easy and consistent as possible. The last set of recommendations that we have is for researchers to continue to investigate the needs, experiences, and outcomes of patients who are underserved. Since the use of telehealth has shifted so dramatically in recent years, we don't yet understand how and when telehealth is working for patients who experience the greatest barriers to accessing care. In addition to that, providers are also continuing to seek guidelines and recommendations about the appropriate uses of phone and video visits. So there's a big role for research and evidence there. And research has the opportunity to evaluate new technology and uses of telehealth to assess its long-term impact and to help us understand how it's working on the ground, under what conditions, and with which patients, so we can keep spreading the practices that work. You can find the comprehensive roadmap and report at the QR code over here, as well as within the chat. There are some links posted. And with that, I will turn it over to Mei Kwong, who will be facilitating today's panel.
Thank you, Natasha, and thank you everyone for being here today. As mentioned, my name is Mei Kwong. I'm with the Center for Connected Health Policy, and I'm happy to be moderating our wonderful panel today. Just before we get started, I want to make a quick reminder that if you have a question for our panelists, we will have some time afterwards for some Q&A. Please put it into the Q&A box, which you'll see at the bottom of your screen. Now, I'm going to ask our panelists if they can come on, turn on their cameras and introduce themselves. And we will start off with Dr. Elaine Kung. Elaine?
Thanks for having me. I'm Elaine Kung. I'm an associate professor at UCSF. I practice primary care at San Francisco General Hospital and do research largely focused on digital health equity and implementation science. Glad to be here.
Thank you, Elaine. Erica?
Hello, everyone. My name is Erica Holmes, and I am the chief over the benefits division here at the California Department of Healthcare Services, and my team is responsible for Medi-Cal medical benefits coverage policy, as well as modalities for delivering care, which would include Medi-Cal's telehealth policy.
Thank you, Erica. Dr. Rubina?
Hi there, my name is Barbara Rubino. I am the Associate Chief Medical Officer at Covered California. I manage our health informatics team within our Health Equity and Quality Transformation Division as well, and I'm a practicing primary care internal medicine physician.
Thank you, Dr. Rubino. Mark?
Hi, my name is Mark Schwer. I'm the Director of Telehealth Services for the Centene California market, HealthNet of California, and I'm responsible for development and execution of telehealth strategy for the health plan.
Thank you, Mark. We're just going to get right into it because I'm sure you want to hear all the great insight that our panelists have. My first question for you all is, when you look at telehealth and how it's being utilized now, what's most exciting for you? For example, are there any innovative practices that you see occurring now that you think should really be scaled? Mark, why don't we start off with you?
Yeah, thanks, May. So what's really exciting for me is not only the pace, but also the breadth of innovation that's happening. Every time I go to conferences, it's mind-blowing how quickly and how broadly telehealth is being considered and developed. When I first started years ago, it was really there was a perception that telehealth was almost experimental. There were limited experiences and pilot programs that were happening. And then we faced some tailwinds, obviously, with the COVID pandemic. And as we created, the people created flexibilities and policies that then transferred over to permanent policies post-pandemic. We've created a environment that really is conducive and is supportive of health systems and development of telehealth. So it's the pace is picked up very quickly, and as was pointed out earlier, what's really important to us as a health plan is our members have access to cost-effective, clinically effective care, and aren't facing barriers to get to care and relying on the ER as a focal point of their care. Telehealth is becoming more and more a patient choice, as you're seeing in many health systems now, where members are given the choice of in-person visits or telehealth visits, which I think is really breaking down a lot of barriers. So thanks, May.
Thank you, Mark. Erica, what are your thoughts on this question?
Sure, May. It's a great question. So, from both a personal and professional perspective, it's been particularly exciting for me to see the very dramatic evolution of Medi-Cal telehealth policy over the years, specifically since I started with the department back in about 2015 till now. For our Medi-Cal population, which I think, as everyone knows, is about 15 million members strong at this point, the broad-based availability of telehealth modalities as an alternative option to more traditional in-person care has really dramatically changed the overall medical healthcare delivery landscape and fundamentally improved, in many cases, the way in which our providers are able to have flexibility to deliver services to our members, and both the way and frequency in which our members are able to also access clinically appropriate and necessary healthcare services, which I think, as already was discussed on the call today, really allows us to better reach historically underserved populations as well as the more rural areas of California. So looking forward, I'm just really enthusiastic about what comes next as technology continues to advance, and we're continuing to think about how there might even be more new and innovative opportunities for making further refinements and enhancements to Medi-Cal's telehealth policy.
Thank you, Erica. And as both you and Mark have pointed out, there's just been a lot of rapid evolution over the last couple of years, especially. Now, I know when talking to policymakers, a lot of time when we inquire about certain policy changes, they always ask about evidence and how can you ensure that everybody be treated equitably. So, what kind of evidence and actions do you think we still need to ensure telehealth is reaching all patients equitably and being used in the most beneficial ways? And I think I'll start off with Dr. Kuhn with this question.
Great, May. Thanks for the question. I think just first thing is when we talk about evidence, we think a lot about specifically clinical outcomes, which are really important, but I just want to highlight that there are other outcomes that are worth considering, right? If you think about the IHI principal aim, thinking specifically about equity, but burnout, care experience, and cost, those are also important outcomes that I think we have a lot less evidence about. Specifically with regards to sort of clinical outcomes, as you saw in the earlier presentation, there's good data in certain clinical settings, but I think some newer uses of telehealth have really come up in the last couple of years, thinking about using telehealth for triaging prenatal visits and having some clinical outcomes in those spaces would be really helpful. But I think in particular, what would be most useful actually with regards to evidence is actually a lot more implementation and real world evidence. So the reality is right now we are in a hybrid care delivery model. We're not going back to sort of where we were before. And telehealth is now sort of along the spectrum of care options. And I think clinicians, policymakers are really struggling with understanding sort of what's the right mix of telehealth versus in-person, and really having a framework for when to reach for audio visits, video visits, e-consults, remote patient monitoring, sort of the spectrum of telehealth options would be really helpful in understanding sort of what that mix looks like for different clinical scenarios, different conditions, specific patient populations. And then the second type of evidence I think we just don't know very much about is, as you heard from Natasha's presentation, we know there are lots of implementation challenges that are actually at the clinical care system level, the health system level, the clinic level, and really understanding barriers and facilitators to really optimizing care telehealth implementation in safety net settings, in particular, how to incorporate team-based care and what infrastructure or restructuring of that care model is needed to support telehealth implementation would be really helpful for advancing equity in California.
Thank you, Dr. Kuhn. Dr. Rubino?
Yeah, I have to agree with so much of what was just said by Dr. Kuhn. I do think we have evidence in what patients say that they want. This patient preference for them being involved in the choice of modality, working with their care teams. This is evidence that we hear from patients. We have evidence that there's benefit to using virtual visits with a known trusted provider or care team member, or a digital health intervention supported by a community health worker. So there are these bright spots in the evidence. And so I think I'm very aligned with that response that we just heard, really focusing our actions on what we can do to address the implementation gap. So despite what we know about patients' desires, despite that we know that when used, this can be a really valuable tool in a care team's toolkit, we see telehealth rates declining year over year when we look at Covered California primary care data. So a couple of actions I'll talk through. I think the first one is to look at what the data tells us. I think the solutions are quite different depending on the care setting, the payer type, the type of clinical service being delivered. So, for example, in our annually published plan performance reports, we see telehealth and behavioral health represents over 75% of all visits, no matter how we stratify. We stratify by race, ethnicity, income level, language, and we see that sort of persistent across the board. Very different story when we look at telehealth use in primary care for our Covered California members. We see more disparities. We also often hear about telehealth as a way to boost access to primary care in rural areas. There's quite a significant disparity with much lower rates of telehealth being used for our rural members. So again, first action is kind of look at what the data tells us and solution really differently depending on the setting, the payer, the patient need. I think the second and third actions, I would mention echo a lot of what we just heard. I think we need to refocus the discussion and refocus the investment from health plans and clinical organizations in the care delivery system, not around more advanced technology or more technology, but around equipping care teams with the tools, training that they need to use a lot of what's available to them. Which kind of ties into the third action I'll mention, which is to address core workflow issues. When there is technology available, but it's not being used or offered, and it's being blocked from that choice is being blocked from reaching the patient, that's, I think, the third area that really needs some action, really that workflow gap.
Thank you, Dr. Rubino. Mark, as a health plan, what are your thoughts on this question?
Yeah, thanks, May. So it's what is really important to the health plan and me personally is that we ensure that there's equity. We call it tequity, where members have access to devices and they have the acumen and skills to be able to use those devices to access care. They have adequate broadband, and then we are sensitive and to cultural and language in terms of members that we're not leaving anyone behind, that we are able to deliver care and understand how to do that in a culturally and sensitive way. So that is what my perspective is, and I think the health plan as well. Thanks, May.
Thank you, Mark. And Erica.
Sure. So, despite all the rapid advances that we've seen with telehealth modalities, I think it's still a relatively new concept for many of our Medi-Cal members. And so we have not yet reached a point of realizing the maximum potential in this space. So from a pure health access and equity standpoint, there's a few areas that stand out to me that have really the potential to drive systemic change in this space. And many of those were already mentioned by other colleagues today, but I just want to reemphasize a few. So first, just, undertaking efforts to improve and expand quality, reliable internet access, particularly in our more rural areas of California. It's certainly wonderful to have a robust and flexible telehealth set of policies in place, but it's not really meaningful in practice if our Medi-Cal members lack the basic internet infrastructure to actually access those services through telehealth modalities. The second piece would just be ensuring that our healthcare services are provided through modalities that are culturally competent and language accessible, as Mark just said. We recognize California is very large, extremely diverse, and so we want to make sure that our policies take into consideration the cultural needs, expectations, and preferences of our members, which really helps to promote trust and increased engagement. And then third and finally, just sort of undertaking efforts to promote data and digital literacy. Similar to some of the other areas, in order for telehealth modalities to be meaningful, they also need to be fundamentally understandable. And so it's important to be thinking about opportunities to provide resources and tools to help our Medi-Cal members feel more comfortable and confident in navigating different technology platforms, which will help to reduce barriers and increase their willingness to use those modalities going forward.
Thank you, Erica, and great insights from all of our panelists on that question here. Now, as we talked about, there's been a lot of advancements in telehealth, especially in the policy area, especially in the ability for Californians to use it more, but there's still work to be done. So my next question for you guys is, what do you think are the most important actions that we can take in California now, as we go forward to advance telehealth from even like where we are from right now? And I think we'll start off with Dr. Rubino with this question.
Yeah, thank you. As we've heard, there have been these tremendous policy levers put into place. There's been tremendous advancement and diversity of technologic advancement. So I'm going to actually kind of stray from that. And my answer to this question is about going back to basics. So I think the most important actions that we can take across California to advance telehealth and advance equity in telehealth is to go back to this basic concept of using telehealth as a tool to support relationship building with a known, trusted team, whether that's a care team member, a PCP, or other teams, and have telehealth be, again, a tool to keep teams be connected to patients and recenter the discussion around the use of telehealth in the relationship. So how can we, looking forward, really stress and measure telehealth as a tool that supports continuity, which is what we know really does have long-term impact on health outcomes and healthcare expenditures. So telehealth not as an access relief valve or a way to bring new technology into the conversation, but really telehealth as a means to support relationships between care teams and build trust.
Mm-hmm. It's often been said that telehealth should be treated as a tool for the practitioner to provide services as opposed to like the separate entity type of thing. All right, great. Dr. Kuhn, your thoughts?
Yeah, I really, really like that answer because I think telehealth, telemedicine visits, e-consults, like they are just sort of options to try to best address a specific clinical concern for a specific patient. And I think one thing that is helpful and that I think California is a leader in, but can continue to do is what I find is one of the barriers to really thinking about telehealth as a tool is that we have structured our clinical care teams, we've structured our payment models around care being delivered in like a visit by visit basis, right? So that's how we think about care delivery. And that has prevented, I think, care teams, patients from sort of re-envisioning how we can deliver care. And so I think payment models that really facilitate the flexibility to allow, patients and clinicians to, choose the best form of care for a specific issue will really help sort of advance telehealth. Two other things. One is that another thing that I think can be helpful in California, I live in San Francisco, right next to Silicon Valley. We're an innovation hub in California. And one of the challenges for a lot of various telehealth tools is that they've often not been, designed to really center equity or really designed with diverse population safety net populations in mind. And so I really think centering in ways that we can center and encourage these innovators who are designing really exciting things to really focus on making it accessible for safety net systems, diverse populations will be really important. And then the third thing is, and we've heard a lot of this, is that, there's a lot of interest in healthcare systems in addressing health-related social needs. And I think having people really reframe and rethink about digital inclusion as a health-related social need is an important thing to do, really. So thinking about, are we screening for it? Are we adjusting our care delivery to align with it? And all the different ways that you address social needs like food insecurity, transportation barriers, thinking about that for digital inclusion will help us advance digital health access and equity across California.
Thank you, Dr. Hoon. And really important issue that I think sometimes gets overlooked is when you actually design the technology from the beginning, is it going to actually work for everybody who might need to access it? So thank you for bringing that up again. Mark, what are your thoughts on this?
Yeah, I mean, we've got a lot of really exciting opportunities, and it really is about expansion in my mind and access, and that the policy both reimbursement and policies are aligned, and where the delivery system sees support for expansion of services. I mean, we looking at primary care, telehealth, primary care models, school-based telehealth, direct-to-consumer models, and then specialty care where members again have a choice to be able to access these services, and it's not limited to just the traditional in-person visits. So thank you.
Thank you, Mark. We have one more question here, and I'm going to direct it towards Erica because for those who may not know, CCHP, we're actually the National Telehealth Policy Resource Center. So we track all the telehealth policies in all 50 states. And I've looked at all 50 state Medicaid programs. And for those who are not familiar with it, and it's been mentioned before, California is a leader in their Medicaid policies in relation to telehealth there. So that is a fact that I can confirm, given that I have studied the other states' Medicaid programs. So Erica, this question is for you. As one of the leaders in the country, what is DHCS's vision for telehealth moving forward? And, how will you continue to monitor any type of policy changes or current policies to continue to assure access and success in the program?
Sure. So, I can say that overall the department is dedicated to continuing to explore opportunities for further enhancements to our policy. And a critical piece of this work is continued ongoing engagement with our key stakeholders who are integral in creating the policy in the first place. So one of the areas where we're particularly focused is on enhancing our public reporting of telehealth utilization data. One, to foster greater transparency, two, to bolster accountability, and three, to promote more equitable access to our healthcare services. So this commitment involves harnessing the power of data to drive improved and informed decision-making on the policy front by reviewing and analyzing data with clearly defined metrics that'll help us better understand telehealth utilization across the Medi-Cal population. And as a testament to this commitment, and many of you may already know this, but the department created a Medi-Cal telehealth data utilization dashboard, as well as a companion narrative report, which were actually first released back in April of 2024. And those tools are really designed for us to take a systematic approach to collecting and analyzing data, to look at trends on telehealth utilization, which we really think can help us gain valuable insights into how our members, our communities, and our delivery systems are adopting and adapting to different telehealth modalities. And we ultimately hope that, it will allow us to better identify areas of underutilization of telehealth modalities, enable us to employ targeted interventions to improve access and quality of care, and also to help uncover potential disparities in telehealth utilization across our different populations and regions throughout California. Ultimately, the goal here, of course, is for this comprehensive data-driven approach to really drive a better understanding of telehealth utilization data, enable the department to develop more informed and effective telehealth policies that address the diverse needs and dynamics of both healthcare delivery and our Medi-Cal members.
Thank you, Erica. And just to let you know, I have shown that dashboard to multiple folks in other states, and the comments have ranged from cool to amazing. So just to let you guys, that's some feedback you've gotten from around the country there. All right there. Well, we've got some of your questions in your Q&A. Continue to put those in there as you think of them, but we'll get started with the first one. What changes are you having to grapple with based on the executive orders at the federal level? Very hefty question there. So as somebody who works underneath federal funding, it's been like an interesting time. So we just have to wait until really what we see, like further information comes out here. But as far as, and I think there's a question here on like the federal telehealth policy issues, which if that's involving Medicare, which we have not touched upon in this conversation, those are temporary waivers that are in place until March 31st of this year. So we'll have to see what Congress does next regarding that. So we're in a bit of a holding position to see like what happens over the next couple of weeks regarding that. Okay, so for our next question, for Medi-Cal specialty mental health services, we've seen variation between counties on their health policies. Would there ever be statewide policies that address telehealth specifically for SMHS? So, Erica?
Yeah, so I can speak to this generally. I think, as everyone on this call probably knows, there's some very nuanced complexities between our what's called our mild to moderate mental non-specialty mental health benefit, which is managed both by our health plans and through our fee-for-service delivery system, and those more high acuity needs services that are managed through our county behavioral health system, which includes both specialty mental health and substance use disorder services. So there are different services and supports provided both on the non-specialty mental health side and on the specialty mental health side. So historically, we have had policies that have been tailored to address the needs of those populations and the nuances of those delivery systems. So I certainly think we're having conversations in this space, but at this time we do have an established policy for our mild to moderate benefit on the health plan and fee-for-service side, and then policies which in some places are aligned with ours, but in some areas they're also different, just because again there's nuanced complexities involved with our county behavioral health delivery system that have to be addressed. And in full transparency, my team is not responsible for the county behavioral health delivery system, and so certainly we'll take that back to my colleagues who oversee that area for their input as well.
Thank you, Erica. We have a question regarding working in an FQHC. They've noticed a need to upskill our employees so they're receptive to new tech developments. Any training strategies that you're aware of? Dr. Kuhn, I don't know if you have any insights on this.
Yeah, I will just broadly say that we've done lots of interviews with our health system too, and basically with the inclusion of digital health or with telehealth, sort of have this new need to provide patient support that really nobody on the clinical care team owns. And so my quick answer is that I don't know specific digital training strategies, but there's been lots of research specifically in. What I want to say is that I think what you probably potentially need, if possible, is actually a new member of the healthcare team who's specifically like a digital navigator or somebody who actually is equipped to really understand this and has the training to really provide patients with the support with getting on the telehealth tool or actually addressing any barriers to accessing telehealth. But if the person wants to follow up with me over email too, there has been sort of digital navigator curriculums developed that you could take portions of and try to have an existing member of your clinical care team do, but I know people are always stretched thin and folks are often not interested in adding more to their scope of work and not having anything taken away.
Anybody else want to comment on this particular question? The only thing I would add, because Dr. Kuhn brought this up about digital navigators, I do know the Northwest Telehealth Resource Center has a training, online training program for digital navigators. If the person who asked the question is interested in that, you can email CCHP and I'll connect you with the Northwest group. Next question, is there anything you can share about telehealth use for CalAIM enhanced care management? Erica, I guess it's you again.
Yeah, and so just again in transparency, my team is not lead on the CalAIM initiative. It's largely obviously out of our managed care delivery system, which of course is where the vast majority of our members are served. But I will just say that my team has worked in close partnership with my colleagues in the divisions who do oversee all of the various components of CalAIM, and so to the extent possible, we have always taken an approach to align policy across the board. Obviously, there's reasons why under CalAIM we might have to do things a little bit different, but within the department, the goal obviously is alignment to the greatest extent possible when it comes to our telehealth policies.
Thank you, Erica. Mark, there's a specific question here for HealthNet. Does HealthNet plan to include virtual MH, I think they mean mental health, and substance use disorder IOP as an in-network service for their members in the future? Are you looking into any potential partners to deliver that care? Mark, you're on mute.
Sorry, guys, can you hear me now?
Yes.
Yeah, so the drug Medi-Cal would be covered, would cover the substance abuse, and I'd have to take the question back and do some research internally. There's not anything on the radar at this particular juncture, but we're working on continuing to refine strategies. So if whoever asks a question feel free to reach out to me and I can have a broader discussion with you.
We didn't really touch upon this, but I think some of you may have done some work in it or know a bit more about this. Uh, did you do any research on asynchronous communication? So anyone have any thoughts about this? This isn't really something that we talked about a lot in this particular webinar, but out of curiosity, since California Medi-Cal is one of the few states that actually does reimburse for asynchronous delivered services, is there any sort of comment the panelists want to make on this particular question? If not, we can move on.
I can make a comment. You know, I have not personally done research in this area, but as a primary care provider, this is a tremendous tool that for many patients, this is the way that they prefer to access care and engage. And there's a ton that can be done. Yet we see in the literature, and there have been some studies that have come out that that really, I think, highlight the disparities that these types of tools introduce into the system. So there's a study that I can try to find and drop the link of that showed that in like academic medical centers, the responses to asynchronous like patient portal messages were there were significant disparities in who responded to those messages. And patients that identified as different as Black, African American, Hispanic, Latino were much more likely to get a trainee, and patients who identified as white were much more likely to get a response from an attending physician. And so there's really systemic things that I think need a lot more attention here with asynchronous care. Even when the tool is maybe present, how we are actually deploying it in clinics, how our workflows are actually using the tool and or contributing to disparities, I think is a really just important area where I think we could devote more time, effort, and energy to learn from. And again, kind of comes back to that implementation gap that I was talking about. The tools are often there, and how they are used may introduce disparities, even though, again, we know that people do want to be able, some people do really want to be able to access care in this way.
Mm-hmm. It's in the past, definitely there's been a lot of research on how effective it's been used for certain types of conditions and certain specialists, like dermatologists been using it for years and it's been very effective. Ophthalmologists as well too. So yeah, I think it's a little bit of an overlooked modality in that it's not going to be used for everything, but there's some stuff that it could be really effective for. Oh, and Dr. Rubina, somebody was asking if you can share the link to that study as well too in the chat. Here's an interesting question. See, I'm not sure who may want to answer this, but what strategy or tools are in use to screen digital barriers for patients?
I'm happy to jump in. So there are a bunch of sort of standard health-related screening tools. None of them have explicitly like a digital section of it. And part of the challenge is that when you think about digital exclusion, when I think about it, there's sort of the different domains of barriers, right? So one is, do they have a device? Another one sort of internet. And then the third is sort of their skills. And one of the challenges of also screening for those barriers is like the type of device you may need, for example, to do a patient portal message might be different than what you would need to do like a telemedicine video visit. And so one of the challenges in actually identifying a specific tool is like you have to have in mind what use case scenario you are using it for. So that's sort of one challenge. The second is, again, there's really not great validated tools. People have been using, for example, questions from like the census or questions from national surveys that are focused on technology, but those questions often haven't been tested specifically with like patients who have digital exclusion. So we found, for example, that in some of the studies we've done, when you ask a patient, like, do they have a smartphone? A lot of the patients who have some digital literacy challenges actually don't know what a smartphone is. So they might have one, but because it's like not an Apple phone or a Pixel, they're like, oh no, I don't have a smartphone. But then you look at their phone, it's, just like a lower end Android phone. And so, there's sort of some challenges there. So there are things that are out there and people have developed a lot of their own. There isn't anything that sort of is standard or super well tested.
Yeah, it's still a little bit scattered and not quite organized in how they do that. There was one time that a clinic told me one question that they ask of their patients just to check their connectivity is, do they have issues when they watch Netflix or when they stream perhaps from YouTube, to just check on like the quality of their connection? It's sort of like a more accessible way to engage with their patient on like the power of their connectivity. Um, First off, I want to thank panelists. You guys were all great. This was a wonderful discussion here. Thank you also to CHCF for this opportunity, and thank you all for your questions here. We are at time, and I'm going to turn it back over to Diana.
Thank you, May. I really want to thank you, May, as well as our panelists for being here today, for being leaders in the delivery of telehealth, and for the wonderful conversation. I think it's clear from our conversation, California is a leader in this space, and by working together, we can continue to make that a reality. Also, I want to thank Natasha for all her work on this comprehensive report and for sharing the findings with us. And lastly, I thank you to our audience for your valuable time, your engagement, and your continued championship of telehealth. Recommend everyone check out our report for more details. There's a ton of nuggets in that work that go beyond what you heard today. Please share with your networks. Please share the gospel that is telehealth. Remember to please fill out the survey that pops up when you close the window. It helps us with future programming. So from all the panelists and myself, thank you for being here and have a good day.